Hello, everyone. So, coming to the last bits of V to Z. So, V for vas deferens absence, congenital absence of bilateral vas deferens, as I said earlier, is seen in cystic fibrosis, but they have normal testicular functioning. So, when a surgical sperm retrieval is done, they usually have a good outcome, and we are able to get sufficient sperms for ICSI. But we also have to remember that this is an autosomal recessive condition. So an individual who is a carrier of the cystic fibrosis gene can pass it on to the offspring. So it is required to test the partner. And if the partner is also a carrier, then there is 1 in 4 risk of the offspring having cystic fibrosis. And that's the reason why this is a condition where we can offer prenatal genetic diagnosis to avoid a child being born with cystic fibrosis. So congenital absence of bilateral vas deferens, they will have obstructive azoospermia, and this can be managed with surgical sperm retrieval. Next condition, W for web neck women. So this is Turner syndrome, and they will be presenting either with primary amenorrhea or primary infertility. They have a karyotype XO. And if you remember, I said that when they come with hypergonadotropic hypogonadism, one of the reasons could be Turner syndrome. And again, 8% could be mosaics, which means they can have natural conception, although the chances are very low. And if they do come with a primary amenorrhea or primary infertility, the reason is because they have premature ovarian insufficiency. And so we will have to think about using donor eggs for conception in them. The reasons why we would even offer surrogacy would be because these individuals have a 50% chance of having serious health conditions like coarctation of aorta, and that could put them at risk to carry a pregnancy. So think about offering a surrogate. So from fertility standpoint, for Turner syndrome, the FSH would be very high, more than 40 on 2 different occasions below the age of 40. An ultrasound will show low antral follicular count. The uterus is usually small, but they are able to carry a pregnancy so long as their baseline health is good. So baseline health-wise, we have to do a thyroid function test and also renal ultrasound, because they are at risk of having renal anomalies like duplication of the ureter or horseshoe kidney, or other abnormalities. They need to be followed up every year with a cardiac MRI to look for coarctation of aorta. And they are also at risk of developing diabetes, so HbA1c every year, LFTs, RFTs, fasting lipid profile, and also check the bone health with DEXA. Once the DEXA is stable, then it needs to be done every 5 years. And every 5 years, we also have to check audiogram because they are at risk of developing sensory neural hearing loss, and celiac antibodies, because if you remember in my slide on unexplained infertility, I said celiac disease can be one of the reasons which can impact the oocyte quality and quantity, and this is seen even in individuals with Turner syndrome. Next condition is XY gonadal dysgenesis, also called Swyer syndrome. And this is the only condition where an XY individual is born with the uterus. And the reason is because they do not produce anti-Mullerian hormone. So going back to embryology, Mullerian system is what develops into the uterus. Anti-Mullerian hormone in XY is what prevents the uterus from developing. But in such individuals, because there is no AMH, they do have a uterus in place. But the gonads are dysgenetic. So they usually present with primary amenorrhea without secondary sexual characteristics because they don't have adequate estrogen or testosterone. And these gonads are at risk of developing gonadoblastoma. So as soon as the diagnosis is made, we have to think about doing gonadectomy. Once the gonadectomy is done, they are at risk of developing heart conditions, bone health is affected, so think about HRT till the natural age of menopause. And from fertility side of things, donor egg IVF, but they can carry the pregnancy because they do have a uterus. So embryo transplant will be into their uterus, which is sufficiently primed with estrogen and progesterone. Next is Y chromosome microdeletion. This is an important cause for azoospermia in men, and there are 3 variants of this gene. The azoospermia gene A and B are the ones that have a very poor prognosis. A is usually absolute azoospermia, which means even with surgical sperm retrieval, we may not find any sperms. So in such instances, it would be to, the treatment would be to use donor sperms. And if it is AZYB, again, it's poor prognosis, and most often they also have Sertoli-only cell syndrome. AZYC can have severe OATS, which is oligoasthenoteratozoospermia in the ejaculate, or better would be to use surgically retrieved sperms, and then ICSI is the next option. The other thing that we have to worry about is because this is a Y chromosome microdeletion, there is a risk of passing on to any male offspring a subfertility, which is inherited. So think about offering PGD. Finally, talking about Zika virus. This is a virus which is mostly seen in African countries, and it's endemic there. So the things that we are worried about Zika virus is microcephaly and serious developmental disorders in the children. So any woman who has traveled to Zika-prone countries should avoid a pregnancy for 2 months if only she has traveled. And if both or just the male has traveled, it has to be 3 months because it takes longer for the virus to clear out of the system in males. If the person has had symptoms within 2 weeks of returning from the country which is Zika prone, then they have to wait from full recovery for 2 months in women, and for 3 months if both or just the male had traveled, again for the same reason that it takes longer to clear out from the system in males. So that ends my A to Z talk on issues, and thank you very much for your patient listening. And no, this is not a spelling mistake. I started with a Scrabble and now I've come to Wordle, which is the talk of the town. So thank you very much for your patient listening.